Basic understanding of arthroscopic anterior cruciate ligaments reconstruction. For ACL reconstruction, surgery is performed using minimally invasive arthroscopic techniques in which a combination of fiber optics, small incisions, and small instruments are used. A somewhat larger incision is needed, however, to obtain the tissue graft. ACL reconstruction is an outpatient or ambulatory procedure in which patients can go home on the same day as their surgery. The femur and the tibia are the main movers of the joint to allow for the hinge motion. This connection of the femur and tibia is a joint called the tibiofemoral joint. The patella sits on top of the tibiofemoral joint in a groove in the front of the femur. The patella is a floating bone that works as a fulcrum for the quadriceps muscles to function properly. This joint is called the patellofemoral joint that allows the patella to move up and down and the knee bends and strengthens. The ligaments and tendons of the knee. The knee has four main ligaments. The medial collateral ligaments, MCL, on the inside of the knee closer to the midline. Lateral collateral ligaments, or LCL, is on the outside of the knee, and anterior cruciate ligaments, or ACL, inside of the knee and crosses to the front. A posterior cruciate ligaments, or PCL, inside of the knee and crosses to the back. The patient is positioned supine with a padded tourniquet applied in the proximal region of the thigh. Two posts are attached to the surgical table. The first is lateral to the proximal thigh, and the latter is a foot roll in order to maintain a 90 degrees knee flexion. The important instruments needed for ACL reconstruction: basic ACL instruments, power drill, ACL reconstruction set, femur and tibia offset guides, camera handpiece, shaver tips, shaver handpiece, trocar, arthroscopy scope, grafting table, and accessories. Operating room setup for knee arthroscopy and ACL reconstructions, and important machines to be used, and positioning devices, instruments, and arthroscopy cables and cameras. Anesthesia machine, tourniquet machine and cautery machine, arthroscopy tower, irrigations and IV stand, suction machines, back table with your instruments, another table for the graft, Mayu stand for your instrumentations, and other Mayu stand for your arthroscopy connections, camera shavers, and light cables, and positioning devices like side supports and heel supports. The scrub nurse should prepare the instrumentations with four steps. Step 1 is graft harvesting. Instruments needed are Army Navy retractors, cat's paw retractors, Leahy's right angle forceps times 2, tendon stripper, 2 cockers, 2 Kelly forceps, Metsim bomb scissor, tooth forceps, knife blade 10 and 15, hypoallergenic marker. For step 2, arthroscopic camera setup, shaver, and light cables. Step 3, arthroscopy and shaver, trocars, arthroscopic grasper and retriever, arthroscopic probe, knife blade 11, spinal needle gauge 18 or hyponeedle gauge 18, arthroscopic punches. For step 4, for femur and tibia tunneling, femur guide wire, tibia guide wire, femur and tibia offset, chuck drill, 4.5 mm reamer, femur and tibia reamer, long curette. The ACL tear. The consequences of an anterior cruciate ligament tear vary from one patient to another, and it primarily develops in the following ways. The patient develops chronic anterior instability. The knee feels insecure during some movements and can give away. This instability can reveal itself during sports activities or daily life during a sudden change in direction or on the stairs. It can develop soon after the trauma or late. Hamstring tendon harvesting. Hamstring tendon autograft remains a popular graft choice for anterior cruciate ligament reconstruction. The knee is kept flexed and the hip is externally rotated. Using a right angled clamps, retrieve the semitendinosus and strip the hamstring using tendon stripper and free the tendon by pulling proximally and distally away from surrounding tissue. After the hamstring tendon is harvested, the residual muscle is removed on a plastic cutting board. Assemble two soft tissue clamps and the graft preparation station base together. Suture both ends of the graft typically for around 30 mm. Make sure the graft is in good tension by adjusting the clamp. Graft should be covered by a moist sponge. Measure the graft diameter by using the graft sizer. The graft should moderately pass through the hole, not too tightly nor too loosely. ACL reconstruction surgical technique. Drilling femoral tunnel. Choose the right size of the femur guide, depending on the surgeon's preference. Place the hook of the femoral drill guide at the over-the-top position in direct contact with the bony cortex. Different techniques can be used, example, transtibial or medial portal techniques, but the ideal position is the footprints of ACL, or use 10 to 11 o'clock in the right knee or 1 to 2 o'clock in the left knee as the reference. Use the drill guide pin with eyelet to drill through the femur. Then choose the corresponding size of the femoral cannulated heated reamer to create the femoral tunnel, and it is typically 25 mm to 30 mm. Put a cockers to the tip of the pin, pass a suture through the eyelet of the drill guide pin, pull the drill guide pin, and pass one end of the suture out of the knee joint via femoral tunnel and leave another end of the suture in the knee joint. Next is drilling tibial tunnel. Assemble the drill guide pin sleeve, tibial pin marking hook, and drill guide arm. Adjust the tibial pin marking hook to the position of 55 degrees angle or 60 degrees angle depending on the doctor's preference. Place the tip of the tibial pin marking hook in the center of the ACL footprint. Push the drill guide pin sleeve to the bone surface and fix the position. Use the drill guide pin without eyelet. And drill through the tibia and monitor the drill pin tip not to damage the femoral cartilage. To achieve a longer tibial tunnel, increase the angle of the drill guide arm. Then disassemble the tibial drill guide. Only the drill guide pin is left in place. Drill the tibial tunnel using the corresponding cannulated drill bit that matches the graft diameter. Lastly, to pass the graft passing threads through the tunnels, after creating femoral and tibia sockets, the surgeon passes a Vicryl 1 or 2-0 nylon suture through the tip aperture of the drill guide pin and creates a loop. After passing graft threads through the loop, the surgeon pulls the drill guide pin completely out of the femur to introduce the graft passing threads through the tunnel.